Center remains open, safe, and committed. Every single person working at St. Luke's is committed to keep you safe. Always. There are important questions you need to answer before undergoing surgery. Will you be treated by highly skilled surgeons? Will they be performing your surgery in a safe environment? Will you be provided with quality patient care? The answer will all be yes at St. Luke's Medical Center. Choosing a hospital could be the most important decision you'll make. Choose St. Luke's.
A fresh journey awaits you at St. Luke's Medical Center as we redefine patient experience to give you more comfort, convenience, and choices you deserve. Waiting lounges are made cozier and more comfy. We have enhanced our patient room amenities, providing new bed essentials, toiletries, special room features, a complimentary in-room coffee and tea station, and minibar items. To give you quick access to St. Luke's concierge services, including the new and expanded St. Luke's room service menu, a digital compendium is available for you and your companions inside the room. We want to be part of your blissful milestones, so mothers giving birth at St. Luke's will be served with a complimentary 3-course meal on the night prior to hospital discharge. While an exclusive I Am a St. Luke's Baby outfit will be given as a welcome gift to newborns. Pediatric patients also get special treats. Signature breakfast meals will be served to encourage and delight our young patients. For added convenience, our patient care navigators are ready to welcome and assist you, from screening to completion of care to maximize your hospital visit. With express admission, waiting time for patients who are advised to stay in the hospital is lessened. Patients get admitted directly to their rooms. No pit stops, no long queues. St. Luke's in-room discharge system makes the patient discharge process quick and convenient. Our concierge staff will visit you in your room to facilitate and complete discharge inside the room. All these new service features are implemented following strict health protocols. It is our goal to give you a smooth and hassle-free hospital experience. Because your comfort, convenience, and choices matter most to us. It's the quality of service you would expect in a world-class hospital, only at St. Luke's.
At St. Luke's Medical Center, we foster a culture of care. We live by the mission to provide compassionate, patient-centered experience guided by excellence and innovation. We have the vision to be the unparalleled leader in patient care, clinical outcomes, research, and education. And as we uphold and nurture a culture of care, we work with integrity, healthcare excellence, accountability, responsibility, and teamwork. We love life. Our COVID-19 experience has opened our eyes to a lot of things. It makes us appreciate the value of being together. It significantly changed the way we live. We know how much you've missed kisses from your loved ones, getting hugs from your friends, handshake from acquaintances, and seeing the smiles of people you encounter every day. Our situation is not easy. Thank you for the support that you've given to our healthcare workers who are risking their lives to keep us all well. Thank you for doing your share by always wearing masks and respecting our safety protocols. Thank you for keeping your distance today for a better tomorrow. And as we recover from this pandemic together, please know that St. Luke's Medical Center will always be open and committed to safely provide the healthcare you need. It's safe at St. Luke's. Is St. Luke's Medical Center safe? The answer will always be yes. It has always been that for the last 117 years. As long as you need the safest care, as long as you need quality health care, as long as your family needs the best care, St. Luke's Medical Center remains open, safe, and committed. Every single person working at St. Luke's is committed to keep you safe. Always. There are important questions you need to answer before undergoing surgery. Will you be treated by highly skilled surgeons? Will they be performing your surgery in a safe environment? Will you be provided with quality patient care? The answer will all be yes at St. Luke's Medical Center. Choosing a hospital could be the most important decision you'll make. Choose St. Luke's.
A fresh journey awaits you at St. Luke's Medical Center as we redefine patient experience to give you more comfort, convenience, and choices you deserve. Waiting lounges are made cozier and more comfy. We have enhanced our patient room amenities, providing new bed essentials, toiletries, special room features, a complimentary in-room coffee and tea station, and minibar items. To give you quick access to St. Luke's concierge services, including the new and expanded St. Luke's room service menu, a digital compendium is available for you and your companions inside the room. We want to be part of your blissful milestones, so mothers giving birth at St. Luke's will be served with a complimentary 3-course meal on the night prior to hospital discharge. While an exclusive I Am a St. Luke's Baby outfit will be given as a welcome gift to newborns. Pediatric patients also get special treats. Signature breakfast meals will be served to encourage and delight our young patients. For added convenience, our patient care navigators are ready to welcome and assist you, from screening to completion of care to maximize your hospital visit. With express admission, waiting time for patients who are advised to stay in the hospital is lessened. Patients get admitted directly to their rooms, no pit stops, no long queues. St. Luke's in-room discharge system makes the patient discharge process quick and convenient. Our concierge staff will visit you in your room to facilitate and complete discharge inside the room. All these new service features are implemented following strict health protocols. It is our goal to give you a smooth and hassle-free hospital experience. Because your comfort, convenience, and choices matter most to us. It's the quality of service you would expect in a world-class hospital, only at St. Luke's.
At St. Luke's Medical Center, we foster a culture of care. We live by the mission to provide compassionate, patient-centered experience guided by excellence and innovation. We have the vision to be the unparalleled leader in patient care, clinical outcomes, research, and education. And as we uphold and nurture a culture of care, we work with integrity, healthcare excellence, accountability, responsibility, and teamwork. Because at St. Luke's, care is our core. It is our culture. We care for our people as much as we care for our patients. St. Luke's Medical Center. We love life. Our COVID-19 experience has opened our eyes to a lot of things. It makes us appreciate the value of being together. It significantly changed the way we live. We know how much you've missed kisses from your loved ones, getting hugs from your friends, handshake from acquaintances, and seeing the smiles of people you encounter every day. Our situation is not easy. Thank you for the support that you've given to our healthcare workers who are risking their lives to keep us all well. Thank you for doing your share by always wearing masks and respecting our safety protocols. Thank you for keeping your distance today for a better tomorrow. And as we recover from this pandemic together, Please know that St. Luke's Medical Center will always be open and committed to safely provide the healthcare you need. It's safe at St. Luke's. Is St. Luke's Medical Center safe? The answer will always be yes. It has always been that for the last 117 years. As long as you need the safest care, as long as you need quality health care, as long as your family needs the best care, St. Luke's Medical Center remains open, safe, and committed. Every single person working at St. Luke's is committed to keep you safe. Always. There are important questions you need to answer before undergoing surgery. Will you be treated by highly skilled surgeons? Will they be performing your surgery in a safe environment? Will you be provided with quality patient care? The answer will all be yes at St. Luke's Medical Center. Choosing a hospital could be the most important decision you'll make. Choose St. Luke's.
A fresh journey awaits you at St. Luke's Medical Center as we redefine patient experience to give you more comfort, convenience, and choices you deserve. Waiting lounges are made cozier and more comfy. We have enhanced our patient room amenities, providing new bed essentials, toiletries, special room features, a complimentary in-room coffee and tea station, and minibar items. To give you quick access to St. Luke's concierge services, including the new and expanded St. Luke's room service menu, a digital compendium is available for you and your companions inside the room. We want to be part of your blissful milestones, so mothers giving birth at St. Luke's will be served with a complimentary 3-course meal on the night prior to hospital discharge. While an exclusive I Am a St. Luke's Baby outfit will be given as a welcome gift to newborns. Pediatric patients also get special treats. Signature breakfast meals will be served to encourage and delight our young patients. For added convenience, our patient care navigators are ready to welcome and assist you, from screening to completion of care to maximize your hospital visit. With express admission, waiting time for patients who are advised to stay in the hospital is lessened. Patients get admitted directly to their rooms. No pit stops, no long queues. St. Luke's in-room discharge system makes the patient discharge process quick and convenient. Our concierge staff will visit you in your room to facilitate and complete discharge inside the room. All these new service features are implemented following strict health protocols. It is our goal to give you a smooth and hassle-free hospital experience. Because your comfort, convenience, and choices matter most to us. It's the quality of service you would expect in a world-class hospital, only at St. Luke's.
St. Luke's Medical Center, we foster a culture of care. We live by the mission to provide compassionate, patient-centered experience guided by excellence and innovation. We have the vision to be the unparalleled leader in patient care, clinical outcomes, research, and education. And as we uphold and nurture a culture of care, we work with integrity, healthcare excellence, accountability, responsibility, and teamwork. Because at St. Luke's, care is our core. It is our culture. We care for our people as much as we care for our patients. St. Luke's Medical Center. We love life. Our COVID-19 experience has opened our eyes to a lot of things. It makes us appreciate the value of being together. It significantly changed the way we live. We know how much you've missed kisses from your loved ones, getting hugs from your friends, handshake from acquaintances, and seeing the smiles of people you encounter every day. Our situation is not easy. Thank you for the support that you've given to our healthcare workers who are risking their lives to keep us all well. Thank you for doing your share by always wearing masks and respecting our safety protocols. Thank you for keeping your distance today for a better tomorrow. And as we recover from this pandemic together, please know that St. Luke's Medical Center will always be open and committed to safely provide the healthcare you need. It's safe at St. Luke's. Is St. Luke's Medical Center safe? The answer will always be yes. It has always been that for the last 117 years. As long as you need the safest care, as long as you need quality health care, as long as your family needs the best care, St. Luke's Medical Center remains open, safe, and committed. Every single person working at St. Luke's is committed to keep you safe. Always. There are important questions you need to answer before undergoing surgery. Will you be treated by highly skilled surgeons? Will they be performing your surgery in a safe environment? Will you be provided with quality patient care? The answer will all be yes at St. Luke's Medical Center. Choosing a hospital could be the most important decision you'll make. Choose St. Luke's.
A fresh journey awaits you at St. Luke's Medical Center as we redefine patient experience to give you more comfort, convenience, and choices you deserve. Waiting lounges are made cozier and more comfy. We have enhanced our patient room amenities, providing new bed essentials, toiletries, special room features, a complimentary in-room coffee and tea station, and minibar items. To give you quick access to St. Luke's concierge services, including the new and expanded St. Luke's room service menu, a digital compendium is available for you and your companions inside the room. We want to be part of your blissful milestones, so mothers giving birth at St. Luke's will be served with a complimentary 3-course meal on the night prior to hospital discharge. While an exclusive I Am a St. Luke's Baby outfit will be given as a welcome gift to newborns. Pediatric patients also get special treats. Signature breakfast meals will be served to encourage and delight our young patients. For added convenience, our patient care navigators are ready to welcome and assist you. from screening to completion of care to maximize your hospital visit. With express admission, waiting time for patients who are advised to stay in the hospital is lessened. Patients get admitted directly to their rooms. No pit stops, no long queues. St. Luke's in-room discharge system makes the patient discharge process quick and convenient. Our concierge staff will visit you in your room to facilitate and complete discharge inside the room. All these new service features are implemented following strict health protocols. It is our goal to give you a smooth and hassle-free hospital experience. Because your comfort, convenience, and choices matter most to us. It's the quality of service you would expect in a world-class hospital, only at St. Luke's.
Hello, good afternoon to everyone. I am Dr. Madi Malilin, and I'd like to welcome you all to this webinar that the Psycho-Oncology Service is sponsoring. I hope that this afternoon will be full of learning for everyone. We have two wonderful and really good speakers who can discuss the topic well. And you can please just type your questions in the chat box later after the lecture. Then we will proceed with the question and answer. So please settle down, and we'll open the webinar with a short prayer first.
Let us all feel the presence of our Lord. Almighty God, our Father, we praise and thank you for this day. We come to you this hour asking for your blessing and help us as we are gathered together virtually. We pray for guidance in the matters at hand and ask that you would clearly show us how to conduct our work with a spirit of joy and enthusiasm. Give us a desire to find ways to excel in our work. Help us to work together and encourage each other to excellence. We ask that we would challenge each other to reach higher and farther to the best we can be. We ask this in the name of the Lord Jesus Christ. Amen.
Amen indeed. So while setting up the intro slides, this afternoon's topic is about end of life, and we will discuss some very challenging dilemmas na we don't usually talk about this, but I think it's also time now that we discuss this and experts actually discuss these questions that are coming up in our mind, no, as we deal with end of life, death and dying. Ano ba itong mga to? Tama ba yung itong ginagawa namin? Is this ethical? Is that ethical? So our speakers for this afternoon will actually answer our questions in our mind. And if you have additional questions later on, you can just type it in the chat box and we will discuss it after the lectures. So let me introduce our first speaker. She's Dr. Pauline Ann Peronilla Cauton, and she's a graduate of the Doctor of Medicine at the UST Faculty of Medicine and Surgery. She then proceeded to have her internal medicine residency at the Cardinal Santos Medical Center and her medical oncology fellowship training at St. Luke's Medical Center in Quezon City. She is an ASCO, which is American Society for Clinical Oncology. She's an international development and education awardee in palliative care and was mentored by Dr. Janet Abram and Dana-Farber Cancer Institute in Boston. She is also an ESMO Research Fellow in Palliative Care at Princess Margaret Cancer Center in Toronto. Our next speaker is, next slide please. Okay. Our next speaker is Dr. Mary Agnes Busuego. She's actually a psychiatrist. She's a fellow of the Philippine Psychiatric Association, and she did her residency training in general psychiatry and fellowship training in consultation liaison psychiatry at the University of the Philippines, PGH. She then went to do her Masters of Bioethics at the University of Sydney, Australia. She's currently an active consultant at the St. Luke's Medical Center in Quezon City and a visiting bioethics faculty member of the St. Luke's College of Medicine and of the Ateneo School of Medicine and Public Health. Let us all welcome Dr. Busuego and Dr. Caution. So may I only ask everyone to mute their mics so that we will not disrupt the speakers. Thank you.
Thank you, Dr. Amadi. Good afternoon, everyone. Let me just set up my... Okay. Is everything still loading? Let me just... All right. Okay. Good afternoon again. So I chose the title for today to be to give or not to give, because that is the question. Patients and their families often find themselves asking at the end of life. So there are many reasons why decisions are difficult or are dilemmas to begin with at the end of life. And what I hope to illustrate this afternoon is not just because we could or we can doesn't necessarily mean that we should, and vice versa. Okay. So my goal this afternoon is to offer some principles that we can keep in mind to help guide patients as well as their families, as well as clinicians, to navigate the final days or final weeks, so to speak. So for patients especially, to have enough autonomy, or deciding power over how they want to go, as far as the things that we can decide for. Okay? Or maybe like what Dr. Madi said earlier, na hindi natin kasi napag-uusapan. So even just to have a foot in the door, to just open the conversation, or to just think in our minds the possibility na it is possible to decide how we want to go. And it's something that we can and should think about. Okay. So why do we need to prepare and talk ahead, right, before we find ourselves there? Because when we find ourselves in that place that we need to make all these decisions, it's easy to get overwhelmed by the many things na tinatanong po sa atin. No? Do we give antibiotics? Mag-chemotherapy pa po ba? Do we still give medicines to put your blood pressure up? Do we even hook the patient to a mechanical ventilator? Is it needed, still needed, etc.? Resuscitation, IV fluids, any form of nutrition, etc. So I think the question na, do we still give this? No, the question of still is an important clue to pick up. No, meaning the opposite, na hindi na natin siya ibibigay, is actually an acceptable option. Okay. So to facilitate our discussion today, allow me to present 3 commonly encountered scenarios with patients and families and the different dilemmas that we often see in our practice. Okay. So this is case number one, which I've called give the basics. We just need to give the basics. So this is a 68-year-old female who was diagnosed with breast cancer stage 4, metastatic to the lung and brain. She initially was under a clinical trial for her case, metastatic breast. But when the treatment stopped working, she was exited from receiving further treatment, obviously. So she was recommended to take a second line treatment, which is oral chemo and HER2 therapy, the lapatinib and cape. But because she no longer had financial support from the study, she had to shoulder the expenses. It was rather inconsistent. It was hard to remain compliant to the treatment. So it wasn't a surprise, therefore, that she suddenly was rushed to the ER one day, gasping and drowsy. And of course, initial sagot po sa ER when you see a patient presenting that way, she was intubated, although she never regained consciousness anymore. So she was admitted to the ward. She was on TPN, which stands for total parenteral nutrition, meaning it's nutrition. If you've probably seen it, it looks like a very thick milk that goes into intravenously. And she was being given fluids, some medications, and she was on ventilatory support. And the daughter was by her bedside and was talking to the doctor doing his rounds. And she was conflicted. She was like, is this what my mom would have wanted? Hindi naman po mali itong ginagawa namin, di ba? Na giving all these things. Is there more that we need to give, or should we not have brought her to the hospital? Of course, it's in the absence of any advance directives, no, or mga bilin na binigay ahead of time. And this well-meaning doctor, of course, not wanting the daughter to feel any guilt, no, or to feel bad, any worse than she already was, would say, you know what, you're giving her food, you're giving her air to breathe, and you're giving her a place to be comfortable in the hospital. And of course, the term comfortable is quite relative. But the doctor says, I think you're just giving her the basic needs. So there's nothing wrong with that. And I guess the question there is, what is basic? What are the basic needs? Okay. The second case that we will call give all, give everything. So this is a 73-year-old female with colon cancer, with recent documented metastasis to the lung and brain as well. This patient has gone through different cycles of treatment already, underwent surgery, as well as how many lines of chemotherapy. So upon receiving these news of new metastasis, she says to her oncologist, you know what, I'm ready, doc. Whatever happens, I'm ready. Although nothing written, nothing official. Again, she also was brought to the emergency room unresponsive. So, marami po siyang anak. Yung son niya sa Manila, who's been the one always taking care of her, realizes that she's been through a lot and wants her to be comfortable. He knows that whatever decisions they need to make, he knows that it should be towards making her more comfortable. But the older daughter, the ate, who is overseas, wants na gawin nila lahat, do whatever it takes. Please do whatever it takes. Lalo na pandemya, hindi siya makauwi agad. She really wants to make the effort to be able to see her mother again. So please do whatever it takes. And lastly, the case I would like to call give up. Okay, so this is a 55-year-old female, breast cancer, initially stage 3, underwent surgery, natapos na rin po yung chemotherapy, pati radiotherapy. And then all of a sudden, at the 1-year mark after treatment, she was suddenly feeling all sorts of things, difficulty breathing, sumasakit sa katawan, hirap sa pag-ihi, etc. So eventually, on evaluation, nakita na metastatic na rin po siya. So in different parts of the body. And at this point, the patient is feeling a lot of things. And most markedly, she's feeling a lot of pain. So alam niyang yun ang pag-uusapan with visiting her oncologist. So umpisa pa lang sinasabi na niya, I don't want anything anymore. I don't want chemo anymore. I don't want any radiation anymore, etc., etc. And in this moment of pain, she says to the doctor, please give me something to end my suffering. If you give it to me, I promise I will not sue you. I will not I will tell my family to not file anything criminal against you. Please, doc, I just want something to end it all, to end the pain. Okay. And so these three cases are specific cases, but can also be any case that we've encountered. The question of what are the basics to give, giving everything, and patients who want to give up already, right? But what should we give? What is the right thing to give? So I want to share with you just this video of, I would say, if you would ask me what are the basics, what should we give, it would be this. Things tend to be different. Priorities and values tend to be different a bit during the end of life. And I hope this video will show us what we do not do. Okay. Parang uulitin ko, diba? So before we can even talk about should we give this treatment, should we still give these kinds of medications, this form of nutrition, etc., this procedure, there will never be just one answer for those things. So let's be clear first on what's the most important thing. It's important for us to establish that what we should be giving first before everything else is our care, is our presence for the patient, our compassion. We need to be giving them a voice in the conversation, especially if we fail to include them in the conversation about their life and about their treatment. We have to give them what they need to be able to live as well as possible for as long as possible. Okay, and it's not just one thing. So this is what's most important. We need to establish this, and if everyone is in agreement with this already, then all the other questions can be answered if they address our primary purpose, our primary goal. Okay, so let's just go again, revisit these cases that we've talked about. So what are the basics? What are we obligated to give, morally speaking? And I think the summary here would be to determine what is extraordinary measures and what are ordinary measures. And that is a very important question because ordinary are what is obligatory. No? So yung tinatawag po na ordinary measures, yun yung morally obligated na ibigay po natin. Okay. So this, I want to read the definition of what ordinary measures means by, actually this is a theologian, Gerard Kelly. He says, all medicines, treatments, and operations which offer a reasonable hope of benefit and which can be obtained and used without excessive expense, pain, or other convenience. So again, let me point it out to my very handy diagram here. It's any intervention, whether it's medication, treatment, operations, any procedure, which offers, and this is the most important thing that you need to establish, a reasonable hope of benefit, meaning it will bring some good, no? And again, that is of differing levels, right? Which can be obtained and used without excessive expense, excessive pain, or excessive inconvenience. Okay, so meaning if it does not at the onset offer any reasonable hope of benefit, if it's a very, very small chance, it's not a reasonable hope of benefit comparative to what it asks for in return, right? And this is the factor of the equation that your clinician, your doctor can help enlighten you with, right? So if it does not offer a reasonable hope of benefit, and it incurs too much expense or too much pain or too much inconvenience, then we can say that measure, that intervention is extraordinary, right? And so you will see that there is no one size fits all na this measure is usually extraordinary. It really depends on the patient and everything else going on surrounding the case, right? So it's not just the medical chances, you know what I mean, of benefiting the patient, pero it can be different from one patient to another. A measure can be extraordinary for one patient, but it can still be ordinary for another, no? Maybe for one family, even just blood transfusion, which incurs its own cost, might be too much, and therefore be extraordinary just for that family, just for that patient. And even within the same case, even with the same patient, a measure can be ordinary, like in the first few days, but later on with added burden in every sense of the word, it can become extraordinary later on. Okay, so basically, you need to see that it's not, just because it's an expense um, type of burden, um, it still is extraordinary, right? Um, and it's not, and that's where we see also the families na, um, even if there was no reasonable hope of benefit, um, pero sinanlala lahat, pati yung mga lupa, pati yung mga bahay, and then when the patient leaves us, the family is left with nothing, no? And so that's something they have to do. So those are things that you need to consider. So particularly for this case, it's important to define, with the help of your doctor, but ultimately, really, it's a joint decision. It's, ideally, it's a joint decision making. So for this particular case, she was receiving IV nutrition, which is not inexpensive. A bag can be anywhere between 10 to 12,000 per bag, right? Which would last maybe a little under 48 hours. Fluids and of course ventilatory support as well. For this particular patient, she was not admitted at the ICU, but that also happens quite a lot. So for cases like this, it's important to realize that withdrawing life support, and again, this is end of life, it's following the course of the disease, which is her metastatic breast cancer, right? When we withdraw life support, not just ventilatory support, in some cases, even the nutrition, because it's not at that point when the patient dies, because it's not a question anymore of if, but when the patient dies, it's likely not going to be because we starved them to death, right? Because there is a bigger reason why there was impending death. So withdrawing or withholding the nutrition, the fluids, the ventilatory support in certain cases, such as this one, we do not do those to will death, or to bring about death sooner, but rather it's our acceptance that it is coming, and we can no longer impede its coming. So it's basically acceptance of the inevitable, and therefore it is morally acceptable. Okay. So next case, give all. So this might seem similar in the sense that it's a question of whether or not we discontinue futile treatment. So ibig sabihin, it's not going to help the patient significantly, if at all. But for this particular case, I want to focus on the family dynamics, which often, not often, but almost always comes into play when making decisions such as this, especially us, we're Filipinos, at hindi lang na dahil closely knit family ang Filipinos, but also because we are a migratory people. So we have a lot of relatives, who are trying to, well, rightly so naman, part of the decision making, but trying to do it remotely, right? So an important question for cases like this is who decides, right? Who is the right person to decide, right? And I show this because essentially, I mentioned earlier that we need to give the patient a voice in the conversation, because we need to remember na yung, if we can allow the patient to make his or own decisions, his or her own decisions about her care and his care and preferences for end of life, that should be priority. Which means, ito po ay pinag-uusapan before a time comes that they can no longer speak for themselves, right? So this would be, kumbaga, the better scenario, rather than the children or the parents or the siblings or the spouse having to make that decision. And of course, there are exceptions, but a lot of times when you present this to the patient, they would want to make the decision because they don't want to place that burden upon their loved ones, right? Because that is really the harder scenario, but it's the most often thing that happens. in from what we see. Okay, so how do we try to elicit the patient's wishes? And these are the three things that I feel we need to be able to provide. Number one is information. No? So really to disclose as much as the patient wants to hear. No? So we can always ask permission. How much do you want to know? We do not assume that they cannot take the news. We ask them, how much do you want to know? Right? Because only the patient can say that. No matter how much we feel, we know the person. Right? So we want to give as much information as necessary, and we want to give them time. So again, when we delay including the patient in the conversation, we are actually stealing from the time they have, the little time they have usually, to be able to process these things, to think about these things, to pray about these things, and to settle whatever businesses they want to. You know? And also the space. And what do I mean by giving them space? Because a lot of times, even if we have a patient who wants to talk about these things, gustong magbilin na ito yung gusto kong mangyari kapag mamatay na ako, etc., etc. When we don't give them the chance to say these things, no? As an example, when we say, huwag kang magkasalita ng ganyan, no? Just laban lang, no? Magdasal ka lang, kaya natin yan. It's like we're shutting them up, right? We are not giving them the chance to actually prepare for what they seem to have already accepted, right? So it is not easy. No, it is not easy to listen to. It is not easy to give, right? But what we try to provide for them is really that chance to go the way they want to go. And really, there will be patients who will entrust those decisions to the relatives. But the thing is, we need to give them that chance and that choice. Okay. All right. And then third, for the patients who want to give up. Okay. Ayoko na. How do you respond to something like that? Because although we know euthanasia is not legal or not practiced here in our country, hindi po natin maiiwasan na merong mga pasyente who will express this, no, out of like, you know, where they're coming from, right? So rather than diminishing their space, like how I talked about before, to process their emotions, you know, we need to try to see where are they coming from. And obviously, it's sometimes we have to really go into the nitty-gritty of where they're coming from. Obviously, they have cancer, they're dying, etc., etc. Pero minsan we need to be able to articulate the particular thing. Why? So that, kasi baka may mga ibang bagay po doon na pwede nating i-address at pwede nating bigyan ng lunas. No? So basically, why? Where are they coming from? Why are they hurting? What is the source of their pain? Okay? Because we want to seek to alleviate. We want to seek to palliate. Okay? So usually, why would anyone want to end their life? Why would anyone, and when you think about it, that question is not just for end of life issues. No? Why would anyone want to end their life? Because there is pain. There is too much pain, and there doesn't seem to be any way out, right? So when we have a patient who expresses these things, let's try to alleviate the pain. So we have to recognize as well that pain is not just physical. It's always beyond the physical. But I do want to say, though, that when physical pain is present, that is the only thing they will feel. When I say only thing we will feel, you cannot begin to try to address the anxiety, the interpersonal burden or issues, or even the non-acceptance of death or pain, or illness, if you don't address the pain, physical pain. So that's where we need to be aggressive in addressing pain. No, we have a lot of palliative and pain specialists um, who can help us with this. So first you need to address the physical pain, whether by medical means, or sometimes there are procedures that we can do, not to change the course of the cancer or of the disease, but basically to address the pain. So always first address the physical pain. Then you can talk about all these other issues that the patient is facing. For sure, they are also facing these other sources of pain. So address the physical first, and try to address what are you anxious about. Sometimes they're anxious about um, the uncertainty of death. So even if sabihin natin we have certain religious beliefs about what comes after, in the end, when you're at that point, you will feel that you don't really know. So there is that support that we can try to provide during those times. Interpersonal, ibig ko po sabihin, there might be some thank you, or I'm sorry, or I forgive you, or I love you, or even just really saying goodbye to certain people. Certain relationships that need closure, perhaps. So yung mga unfinished business in every sense of the word, na kailangan nilang gawin, maybe dala-dala nila yon. There's suddenly this realization that they need to address these things. And the non-acceptance. So that is a burden in itself, meaning I always say denial is such a powerful force. When you refuse to accept the situation where you are and where we're going, and that is such a heavy burden, not just on the patient, but everyone else. When the patient insists on pursuing something, a treatment that probably won't work anymore, that has no reasonable hope of benefit. So all these things really need to be addressed. So it's not just shutting the conversation if they ask for something to end it all. Rather, of course, it's important to just be there, to be present to the person, to the patient, and sometimes even the silence is so golden, in the sense that they just need to feel you near them, and to really hold their hand. But later on, to really try to help process, where is the pain? Where is the pain? And maybe we can help, right? And I guess I show this because, and I want to tell you also, there are a lot of studies that sort of look into this, asking patients, asking their families during those last days, when they think about it, what made it or what makes it a good death, for everyone involved, right? So sometimes it's for the patient to maintain some sort of control. Na yun nga, having a voice in the conversation. Good symptom management is so important. Opportunity for closure, affirmation that they are loved and of their worth, and really that they live a good life, right? And again, this is the acceptance, recognition of, and preparation for impending death, and not being a burden. And that's why it's important to remember that even just something being of excessive expense, right, is actually a burden the patient might carry. If alam niya, that anxiety and worry na ano na mangyayari sa pamilya ko, if they give everything just for a procedure that probably basically is not 100%, maybe not even 50%. Okay? So this, I think, is my last slide, and basically, to give or not to give, my conclusion would be: give compassion, give love, give care. And then if that is your primary purpose, then let that direct all the other decisions that you need to make. Thank you very much.
Thank you very much, Dr. Pauline, for that very informative discussion. And indeed, compassion is actually a thing that we have to always put in our minds as we encounter patients and their families, no, facing death. So we can now proceed to our bioethicist, Dr. Meg Busuego. Okay, I'm giving you now the floor, Dr. Meg.
Thank you. Can you hear me?
Yes.
Okay. Let me just share my screen. All right. Thank you very much to Dr. Malilin and the Cancer Institute for the invitation. I think you probably find that a lot of my slides are very wordy. You don't need to read the slides, just listen to me. Okay. And I repeat some of what Dr. Cotton said, but I guess in more detail. So I will follow this outline, I will give you a definition of terms of beneficence, palliative care. Dr. Cotton already said what a good death is, but I'll go into that also, and futility. And then we'll discuss some issues in ethics that are seen in life and death. So that is truth telling, consent, capacity for decision making, confidentiality, end of life issues, and withholding life sustaining treatment. So oftentimes we only look at ethics in terms of these ethical principles, but that's really not the case. There are very many more ethical theories that are looked into. Value ethics, but principlism or the basic ethical principles are the most commonly used because they're the easiest. So these are some. There are 4 of them. So when we say autonomy, it is when the person is allowed to be self-governing and to make decisions for themselves. So is this autonomy? The nurse is saying, you're free to choose right or left. Not exactly. If it's autonomous decision making, you've actually got the choice of whether you want the injection or not. Okay? So that is an example of a little bit of paternalism. Doctors telling you what to do. Is that right or wrong? It depends. Beneficence is wanting to do good, basically. The next one is non-maleficence. We try not to do harm. So it's the opposite. And then justice. So we look at it in terms of standards and expectations equally distributed among members of society. So each principle is equally important. There is no autonomy is not the most important principle. No, it's not the case. They're all equally important in all situations. However, we take into consideration specific context. So no automatic precedence. So the answer would that it depends. Okay. For those who are not from the medical profession, you might be wondering, what is ethics? What is bioethics? Bioethics is not just in the medical field. Ethics is a general field, and it's part of philosophy. Essentially, it's what we ought to do. So it's a prescriptive process. When your doctors give you a prescription, we would like you to do it. So in this case, ethics tells us what we should or ought to do. It doesn't mean that we will do it because it's a personal choice. Most hospitals will have ethics committees to help guide their clinicians as to what decision could be better. And a lot of companies will also have ethics services to help them. Business ethics, ecological ethics, that's a thing also. Okay? So the next thing that we look at is palliative care. A lot of people actually don't know what palliative care is and that it exists. Even in the Philippines, we have palliative care. I would like to stress that. Um, it is the study and care of patients with active, progressive, far advanced disease with a limited life expectancy and for whom the focus of care is the quality of life. It doesn't mean that once you refer to palliative care, ay mamamatay ka na. No, that doesn't necessarily mean it that way, no? The focus is to give you a better quality of life. Doesn't mean that you're dying now. Would mean that yes, you might be dying in the future, but we are all dying in the future. We're all in the process of dying, honestly, right? Another euphemism for palliative care is actually comfort care. Because palliative care has such a bad rap now, so sometimes we say, oh, please refer to comfort care, or please refer to palliative care for comfort care. The strength of having palliative care in your medical team is that they help focus on the quality of life rather than cure or prolonging your life. You know, doctors, we're all trained to save lives kasi. In the very beginning, we're all trained you have to save a life. So that's the problem. Sometimes we want to save a life that perhaps quality of life may not be taken into consideration as much. Okay? Going to medical futility. Uh, because technology is so advanced now, this happens, that we still have a lot of diseases that we know nothing about and we can't do anything about. And cancer is one of them, that there are still many cancers that we cannot control. And at some point, even your doctors will have to say, looks like we're not going to be able to do anything to solve or get rid of the disease. So when we say it is futile, the burdens of a medical therapy seem to be out of proportion for any possible benefits. No matter what you do, no matter how much money you have, no matter how much medicine you put in your veins, it won't make any difference. So again, this is related to thinking about quality of life. And then what is a good death? You know, Filipinos, we don't like talking about death actually. And a lot of doctors, oncologists, internists, cardiologists, surgeons, they're very uncomfortable with talking about death. But I encourage you to start this, to start being comfortable. Usually kasi when we do our interviews, especially for psychiatry, the things that make us uncomfortable, sex, gender, death. So those are the things that you have to be matter of fact about. Have you ever thought what you would like to happen if you are at the end of your life? Okay? So no discomfort whatsoever and no pauses. Okay? So a lot of people will actually define a good death as no pain. I just don't want to be in pain, doctora. I'm ready to die, but I'm scared of the pain. Okay? Again, I get to quality of life. Sometimes kasi the patients aren't given enough information. They don't know what to expect. They're not offered the information and they're not offered psychosocial support. So a lot of times it's up to the doctors actually to offer it because our patients are not aware of what facilities are available. We're lucky in St. Luke's we have all of this. Smaller hospitals, they don't have it, but you have a psychiatrist, a general psychiatrist, no matter, even if you're not a consultation liaison psychiatrist, you are equipped or you should be equipped to handle taking care of a patient who is dying. So from quality of life, we look at the value of life. Patients, all of us actually, all of us should look at our lives in terms of have I given enough value to my life? Have I done enough for my community? Do they still value me as a person? Or because I am incapacitated, wala na ako. Wala na akong value as an individual. Or do they just keep on telling me it's expensive to take care of me? Those are the things that run through your mind. And then you look at the meaning of life. So, a survey they did said that 75% of dying people actually want to talk about it. It's just that the people surrounding them, their loved ones, their caregivers, might not be feeling equipped to handle it or are also in the grieving process themselves. So they might not be able to discuss all of this with them. So you look at the meaning of life, the meaning of your suffering and of your death. And if no one is interested in discussing it with you, then you might have symptoms that would make it even worse. You have physical pain and you also have emotional pain. Okay? So that's when perhaps a psychiatrist referral is in order. The thing is, the definition of a good death is different for people, for different people. So it really needs to be talked about. Some people, they just say, talk to the hand. I don't want to talk about it. Just give me the medicines. I don't want to talk about my death. Maybe that's how they feel now. Perhaps in the future, not so much. But, you give them the opportunity to talk about their feelings, to balance pain relief and alertness. A lot of times, the other doctors and relatives are reluctant to give pain relief because they don't want the patient to be too out of it, because the pain meds can make you very sedated and sleepy. But there is a fine line, yes. But if you work with your palliative care specialist and your pain specialist, you can have that good line of pain control, and yet your patient is able to speak and able to interact and say goodbye. So there's a balance of pain relief and being alert. And looking at the willingness to tolerate increased weakness, dependency, and uncertainty versus having control. Sometimes even just the diaper. A lot of our senior citizens, they don't want to admit that they're incontinent because they don't want to have a diaper, because it's a matter of control. But if you put it to them in a different way, say, you know what, Lola, if you wore a diaper, actually, once the pandemic is over, we could go to the mall for a longer period of time. You don't have to go to the bathroom anymore. Okay? So you put it in a different way and they will feel a little bit better. You don't put it in a degrading way na, ay nako, naka-diaper ka na kasi, mahal pa. Okay? Looking at a good death requires us, health professionals, to approach patients and families as individuals. So it really is a case-to-case basis. You have to talk to your doctor has to talk to you. And if there's a team of doctors, you have to have a meeting. A family meeting is important. So you as part of the family and you as doctors can tell each other how you guys are planning. How you guys are planning for the treatment and how the family would like to have treatment go. And at the center of it all is the patient. Okay? So you provide care that is consistent both with patient family values and your own conscience. As I said, bioethics, it depends on the person. It's a very personal decision. If you feel that you're unable to handle the patient's bioethical issues, then you can refer to the ethics. I am part of the ethics committee, bioethics committee of St. Luke's. You can refer to the ethics committee of the hospital, or you can have a psychiatrist come in, or you can refer to a second, depends on your specialty, oncologist. But you tell the family, you know what, I'm a little bit uncomfortable with this situation. Perhaps we'd like to have a second opinion. And let me call my friend in who is a specialist in this case. Okay. So essentially, the framework of palliative care, comfort care, is that you try to control the pain and other symptoms. You make decisions on the use of life-sustaining treatment, and you have support of dying patients and their families. So it's not just a matter of, please sign the DNR form, the Do Not Resuscitate form, or do not intubate form. It's not just that. It's a whole slew of decisions. Do you want the antibiotics? Like what Dr. Rakautan said. Do you want the antibiotics? Do you want the fever meds? Do you want all the other interventions? Okay. Of course, your doctor can help you with those decisions, but ultimately, actually, it's the patient and family who will make the decision. So we go to the ethical issues at the end of life. These issues are a little bit difficult sometimes because when it's a loved one involved, it's hard to make those decisions. It's easy now to discuss it. It's hard when you are faced with it already. Okay. Truth telling. Would you, as a doctor, I'm talking to the doctors, would you tell your patient that they have cancer or any other terminal illness, even if the family asks you not to? And that happens a lot, huh? Okay. Actually, in the practice of medicine, we're supposed to tell the truth. It involves the provision of information, not simply to enable patients to make informed choices, not just because we want the patient to make an informed consent, but because we respect them and we want them to know what's happening to them. That's why we tell them. Are you going to go against the family? It's a tricky situation and it depends. You want to ask yourself, why don't they want to tell their mommy or daddy that they have cancer? And a lot of times, mommy or daddy actually knows that there's something wrong with them already. In denial lang kayong lahat. This is, one of the most relevant tests for not telling is that whether you ask yourself, whether telling would in itself cause physical and mental harm to this patient. Meaning, pag sinabi mo, will it cause a heart attack? And then cause them to die? But then, when you think about it, it depends how you disclose also. Hindi naman ibig sabihin na, okay, Mrs. Boswego, you have cancer and you're dying in 2 days. I'm exaggerating, of course. But some doctors actually talk like that. And perhaps a little bit of bedside manner would be appropriate in this case. Okay. But ideally, we should start from the assumption that all patients are able to cope with the facts. When they're not able to cope with the facts or when they're not able to think properly, we'll go to that later. So, when you do not disclose, see what kind of harm that will cause also. Because then you are denying your patient the possibility of a good death. Right? So, morally, how are you going to feel about that? So, veracity is another term, and it is the duty to tell the truth or our obligation for full and honest disclosure. It's related to patient autonomy because you respect the person as a person who is able to decide for themselves, then you will give them the truth. It needs to be accurate and honest. You're not just going to say half truths. You're going to say all of it. And it requires that information be presented in a way that is understood and can be applied. Just because the patient is actually, we had the discussion about this, just because the patient is a medical professional, you shouldn't assume that they are thinking as a medical professional. If you have a patient like that, assume that they're a patient. So hindi mo sasabihin, doktor ka naman, alam mo na naman na laryngeal cancer is really bad, di ba? At that point, they're not doctors, they're patients. It's a matter of trust. Your patient trusts you to tell them, but you also trust them, the patient, to tell you the truth. So it's a mutual respect. The patient's right to be told is actually important because it's their information. And it may lead to possible harm if you don't tell them. Because if you don't tell them everything, they may decide, hindi ko kailangan ng chemotherapy. ng therapy ng tablets na to kasi wala naman akong ibang sakit eh. So it may sway patients from getting help when they need it because they don't realize that what's really wrong. Okay? It involves deception and it undermines the confidence in the whole medical profession actually. Because, kasi yung doktor ng mommy ko, hindi sinabi sa amin na she was dying na eh. So ayaw na namin magpa-doktor talaga. Exaggeration, pero kasi may mga pamilyang ganyan. Okay? So good communication is really important. But there is such a thing as therapeutic privilege. So in some circumstances, health workers may be exempt from the normal duty of telling the truth because some effects might outweigh the good effects. But sobrang case-to-case ito. This is really case-to-case basis because it really does damage the therapeutic relationship. Like placebo effect. For example, you had a patient who always has somatic complaints, who always keeps on going to the ER, and then you just give them a saline solution and tell them, pampakalma ito. Doesn't that ruin the therapeutic relationship? And ought you not to be telling the patient, perhaps you have other things wrong with you and not just perhaps it's anxiety and not just palpitations. Okay. Next, we go to confidentiality. Parang simple terms lang, pero when you think about it, theoretically, okay, ito. Have you ever talked about a patient with a colleague in a public space? This is assuming you're a doctor, but actually, even if you're not a doctor, even if you're a relative, do you tell your friends that your mom has cancer? Should you? Without your mom's permission and your mom doesn't want you to say? Okay. Or, back to the medical professionals. In case presentations, is it enough to just give the initials of the patient, but you have specific dates and circumstances in the case presentations that enough to identify the patient? Thank you, Google. So a lot of people Google, it's a verb na, Google people's names. Have you ever Googled your name to see what will come out? So that is confidentiality. We as physicians are obligated to keep information confidential. Again, that comes down to trust. Our patients trust us. So our records are confidential. Do you keep your patients' files in a secure space? Actually, I think you see you see some of my filing cabinets. I love filing cabinets because all my patients' files are locked up. When you do online interactions with your patients, do you record the meetings? Do you ask them permission? And do you guarantee the safety of their recorded files? So these are part of patient confidentiality. It's difficult then now because hindi pa pala. That was the next slide. Confidentiality involves, again, respecting autonomy and patients' rights. So I just want to differentiate privacy and confidentiality. Confidentiality is restricting private information revealed in confidence. Our privacy is ownership of our own body or our own information. Okay? So we don't talk about patients in the corridors. If we do talk about patients in the corridors, we strip of all information. Pero talagang actually, it's very hard. The nightmare of talking about a patient, not even saying their name, and then the patient's family behind you. May mga true stories na gano'n. Okay? However, in the Philippines, confidentiality can both be socially and culturally determined. Who goes with your family member when they consult? In other countries kasi, it is the individual. They're very individualistic. In our society, it's a communal thing. So, the barangay comes. Even with psychiatrists, I have had patients, they will say, Doktora, pwede bang sumama yung mga kumari ko? Kasi alam naman nila kung anong nangyayari sa akin. It's not even relatives. It's her neighbors. It's her friends, friendly neighbors. But they really knew what was going on. So how did I deal with it? I said, Yeah, sure, they can come, but can I talk to you first? And then they can come in after. Uh, and as I said before, record keeping is part of confidentiality. Okay? Uh, the problem now with record keeping is that, um, like in the charts, how many people have access to charts in the hospital? Actually, a lot. Because it's not just the doctors, it's the nurses, it's the nurse aides, it's respiratory therapists, all the therapists. Um, so they have, even the dietitian have access to charts. So they really have to make sure that they are part of that confidentiality pledge. So information technology. Now, a lot of hospitals are going into electronic medical records. So patients have to be aware that their records are electronic now, and um, the hospitals have to guarantee as much as they can uh, that the patient's records are kept confidential. Have you heard of those nightmare talaga? Yung mga hindi kidnapper, the ransomware. They get a hold of hospital's files, patients' files, and then they contact each patient and the hospital and tell them, if you don't give us a certain amount of money, then we will release your files. In fact, there was one, I think, a hospital in Sweden. It was a plastic surgery center. So, there are a lot of people who have plastic surgery and don't tell others that they did. So that was a big hullabaloo. Okay? So competent patients have the right to control the use of information pertaining to themselves. And competent patients have the right to determine the time and manner in which sensitive information is revealed to family and friends. So actually, it's the other way around. With the confidentiality and truth telling, you tell the patient first and then you tell the family with the patient's consent. But again, there is a fine line because in the Philippines, the family is very involved with decision making. Or the other joke was, it's not even sometimes who makes the decisions, it's sometimes who has the money who makes the decisions. Okay? Pero fine line din talaga yun. Informed consent. We go to consent because I talked about competency kanina eh. Who is competent now? Okay. Consent is the autonomous authorization of a medical intervention by individual patients. It is specific and it is a process of communication between the person who is going to do the procedures and the individual or the patient. So, to be able to make a decision, one has to be capable of making the decision. I want to differentiate competence and capacity. It's actually nominal. Competence is decided by the judicial system. Capacity is decided usually by the medical doctors. Doesn't even have to be psychiatry, but usually they ask psychiatry to come in. It is specific. You can consent to your operation, but you also have to consent to other procedures. You consent to an admission, but not necessarily to the procedure. So may mga ganon. And it can change over time. Sometimes the environment changes your consent and your capacity. So when psychiatrists, this is my psychiatrist hat coming on. When psychiatrists come in, what do we look at? We look at adequate cognitive testing. Are you able to make decisions based on, are you oriented to time, place, and person? Do you recognize people? Are you able to speak properly? Is your memory intact? Short-term, long-term, immediate memory. We look at the mini mental status examination. And it depends, if you're irritable, sometimes your mental status is not great. Or if you have other comorbidities. Or if your testing environment is mainit, maamoy, gutom ako, sometimes iba yung cognitive testing. So as much as possible, you get the ideal environment. Is the decision making rational? Is this person who is giving their kidney, for example, have they done blood transfusions in the past? Have they donated their blood in the past? So yeah, it makes sense that they want to donate their organ to someone else. Okay? Is it sensible according to culture and belief? Is it in the person's best interest? I want to give my kidney, but there is a family history of kidney disease and hypertension in my family. We're not going to allow you to do that because it's not in your best interest. You need both kidneys. Okay? Is it comprehensible? Competence, capacity, and decision making is voluntary. It has to be a voluntary choice, free from decision making manipulation or coercion. Okay? And there are internal and external factors. Internal factors, sometimes, doctors, they don't want to do something. For example, if you're a very, very spiritual and very, very religious doctor, like a Catholic, you don't want to do an abortion or you don't want to do certain procedures, you cannot make them do it. External factors. If you practice in a Catholic institution, they might not allow you to do it. See the difference? Okay. Disclosure. These are terminologies that come out in ethics. This is the moral justification respecting patient autonomy. No. The moral this justification of disclosing information is that you respect the person and the person's autonomy. Okay? So again, voluntary decision making is only done when there is adequate disclosure. Meaning, there's lots and lots of information that is necessary. What's your diagnosis? Prognosis? How long do you have? I notice oncologists will not really give you a really good prognosis like, okay, you have 3 months. Ang hirap kasi magbigay ng prognosis eh. They might say na studies have shown there is a 5% rate of passing away, pero they will not give you a tanning. Okay? Options for investigation and treatment. What are the burdens and benefits of this investigation or treatment? Is it conventional or experimental? Who will perform the procedure? What are the consequences of choosing or not choosing the treatment? Is there long-term and short-term outcomes? What is the time involved? What is the cost involved? And all this information will depend on how serious your condition is. If you have an ouchie on your hand, a paper cut or something, it's not going to be that long. But if it's COVID, cancer, serious conditions, then you're going to really have a serious talk with your doctor. You're going to have a long online Zoom meeting. Okay? What is the degree of possible harm? The likelihood or risk of harm? What do the patients need? What is the attitude and understanding of the patient? And after all of this, when you have explained to the patient as family member and as doctor, how can you see that the patient understands you? Ask them. Ang dami natin na pag-usapan. Naintindihan mo ba, ate? Ano ba na pag-usapan natin? Sige nga. Pwedeng ganon. Or, as the doctor, I always tell this to my patients. Information overload, yes. But, are you okay with understanding it? Can you tell me what we talked about? Okay. That is when you can get consent. So consent is again specific. The patient must understand and appreciate the information given to them, and they must be reinforced and repeated and checked for understanding. Just because you told the patient doesn't mean they understood. And the family also. So that's why it's important to have a family meeting with your doctors. So usually when you refer actually to the bioethics committee of the hospital, first thing we ask, have you had a family meeting? Because sometimes it's really just communication. You need to communicate well. Okay? And guys, don't say, ayoko na maging doctor, ang dami palang kailangan gawin. That's really part of doctoring eh. Talking to your patients and talking to their family. Okay? So the decisions in consent, again, I must stress, it's not just about respecting autonomy, but being caring and compassionate towards your patient. Because consent is a two-way process. And, ideally, all decision-making should be shared. It's not just the doctor saying, this is what we're going to do. Because remember, It's the patient's body. And they have the right to refuse or accept treatment. Unfortunately, some patients will choose to refuse treatment despite all the information that is given to them. Consent can be explicit, given orally or in writing, or implied. Meaning, actually, medyo with defensive medicine these days, we usually ask for explicit consent already. Mahirap na sometimes kasi he said, she said, okay lang daw sabi niya eh. Okay? For example, making an appointment with the doctor's secretary and entering the doctor's clinic is implied consent. You're willing to undergo the history-taking process. Yeah? Okay. But some psychiatrists actually will ask for written and oral consent for before that. Again, respect for persons. What are the exceptions for consent? There are exceptions din naman. If it's an emergency, you don't have to ask for consent. If it's a necessity. But there are also limits for consent. You cannot consent to being murdered, i.e., euthanasia or assisted suicide at this point in time in the Philippines, no. But in other places, yes. Oh, we go to end of life issues. O, di ba? Connected naman eh. So, euthanasia, when we look at it, there is active and passive, voluntary and involuntary. Active is actual killing. Passive is letting die or killing by omission, which is what Dr. Cauton was saying kanina. Not giving food or by omission, not giving them medicines. Okay. The problem lies in that, as I said, we healthcare workers are trained to keep people alive. Not keep people alive, to save lives. And with technology now, in actuality, we can keep people alive with, the breathing machines and all the machines. But then we look at quality of life again. Okay? What is the difference between euthanasia and physician-assisted suicide? In euthanasia, the person themselves will pull the plug. In physician-assisted suicide, obviously the physician assists, gives the person the means of committing the suicide. Okay? I also want to talk about voluntary stopping of eating and drinking, VSED. This is not the doctors withholding the food. It is actually the patients deciding they don't want to eat anymore. So this is considered, it's a new thing. It's a newly discovered idea. And part of it is called the completed life initiative. The idea that you feel that your life is complete already. You are not depressed. There is no psychopathology. And yet, because you have a medical illness that is going to kill you in the long run, you want the chance to control when you die. So you decide to voluntarily stop and eat. And they say that this is considered more ethical than physician-assisted suicide. Okay. But FYI, either these are the states or countries that allow for euthanasia or physician-assisted suicide. It depends. Some countries allow euthanasia. Some countries allow physician-assisted suicide. All those countries. I got this from Dignitas. It is an NGO that actually helps people look for places that if their home country or home state does not provide for euthanasia or physician-assisted suicide, they will help you. Okay? Another FYI, all these countries and states except for one, will not let you do it unless you are a resident or a citizen of their country. The only country that allows for euthanasia tourism, quote unquote, is Switzerland. Okay? So we go back to our definition of what is a good death. Some people are very religious. Some people are do not have gods or do not think that there is an afterlife. So it will really depend. But these are some suggestions of what a good death might be for you or your relatives. Having control over pain and other symptoms, having control of where you want to die. Some people want to die at home, some people want to die in the hospital. If you die at home, there's logistics ha. Who will declare your death? May maraming kailangang isipin. Okay. Do they want their family around them or do they want just their most loved one around them? Access to information, expertise, hospital care, spiritual and emotional support. As physicians, we don't tell the patient, okay, I'm going to ask the hospital chaplain to come here. You offer. And don't assume that even if your patient is actually, you know that your patient is not very religious, sometimes they become very religious at the point of death. So you offer it. Would you like, we have a service in our hospital that the chaplain can come here and talk to you. Would you like that? Sense of achieving a sense of completion or closure, whatever completion or closure that they feel, and a chance to say goodbye. A bad death would be perhaps lack of honest communication, difficulties in accurate prognostication. Yung bang, sabi ng doktor ko, 3 months na lang to live, tapos ginawa mo na lahat, tapos 6 months nandito ka pa. Parang hirap nun, di ba? You're kind of glad that you're still here, but then, what am I gonna do? Lack of control, lack of planning end of life care. This is another thing, advance directives. I want to differentiate the advance directives and the living will. Advance directives are physician instigated. We ask you, is there anything you would like to happen? The living will is from the patient. I have decided this. Either way, at this point, the Philippines has no legal law. It has no law towards advance directives. However, if you do have advance directives or a living will, you give it to your doctor and we can follow it. The other important thing is that you discuss it with your relatives so that when the time comes and the doctor wants to follow it, your relatives don't contradict your wishes. Okay? So that's important. There are terms, living will, durable power of attorney, advance directives. Yung power of attorney, special power of attorney, may mga ganon eh. There's a special power of attorney for medical decision making. So, meaning you're giving this person the right to make decisions for your medical needs alone. Or there's a special power of attorney for financial, may mga ganyan. So, that one, you have to talk to a lawyer for that. Okay? And lastly, I think this is the last, treatment and non-treatment. This is Dr. Cautono discussed this already. It is morally prohibited to intentionally kill a person, to intentionally let a person die, or to base decisions on the prolongation or shortening of life on considerations on the kind or quality of a person's life. That is the respect for the sanctity of life. Problem is, remember, sanctity of life, this is a very religious, spiritual concept. There are exceptions already now. Okay? So it really depends on the person, the family, and the medical professional, the healthcare professionals involved. This is the ideal. But then you get the concept of futility again. Okay. You do have demands for inappropriate treatment. Doktora, kahit anong gawin natin, Pero kasi, at some point, no matter how much medicine and how much treatment we give, sometimes it's really futile. So what are demands for inappropriate treatment? Experimental treatment that's not available here or that your doctor is not comfortable giving. Um, Appeals for life-sustaining treatment, but quality of life is not there. So we look at the basis is the standards of care. We always look at what is the standard of care and what is acceptable for the medical profession. Because are you doing too much already for a person who shouldn't be getting it na? Okay? So, again, it comes down to effective communication. And then we go back to family meeting, an appropriate family meeting. Because as much as possible, it is a shared decision making, a negotiated solution. Legal recourse is the last. Legal recourse meaning, ay nako, I'm going to sue, I'm going to go to courts and ask them to give my mom this medicine. Which is what happened with if you have been following the news about the ivermectin in the States, and the courts actually were dictating on the doctor and the hospital to give ivermectin to the COVID patient. They overturned it, by the way. But yeah, it's difficult if the courts start to intervene like that. So as much as possible, you try to find a solution without going to court. I think that's about it. So in summary, palliative care provides services as they are needed along the complete continuum of diagnosis of life-threatening diseases through to the unpredictable period of disability, functional decline, and the last phases of active dying and family bereavement. There are many ethical issues that are present at the end of life, and these should be actively discussed between the healthcare professionals and the patients and their loved ones. Thank you.
Thank you, Dr. Meg. It's indeed a comprehensive discussion of not only futility and beneficence, but everything about the end of life, bioethics itself. So, do you have any questions? We have a lot of medical intern students here. You have to ask questions. Just type it in the chat box, please. Okay, siguro I have a question for both of you. So, case scenario, the patient is actually a 75-year-old male with dementia admitted because of abdominal pain, which turned out to be cancer, liver cancer. So, how do you go about disclosing and informing the patient or the family on the treatment or the management?
Cancer kasi. Joke.
Dementia, di ba?
Yeah, so that makes it difficult. So I think from what Dr. Basuego also shared, the capacity is in question to make that decision for himself. No? So without going through how severe the dementia is, definitely this is not something that you can just discuss with the patient. Kailangan the family needs to get involved. Usually, so a general statement maybe that I could say is that if the patient is incapacitated for whatever reason, whether it's dementia or unconscious na si patient, if wala po siyang naunang bilin about what they want, etc., how I would guide the family is sa pagkakakilala nyo sa inyong father, male nga ba? Male, di ba? Or inassume ko lang, oo. Sa pagkakakilala nyo sa inyong tatay, what would he have wanted? And during a time na he was had full capacity, mental capacity, etc., of what you know of him, of what you know of his values, and what is important to him, how would he have decided? And to start from there, na to try to look at it from the viewpoint of the patient rather than the individual values of the family members. No, so to still try to direct them towards focusing on the patient rather than their own decision. Yeah, but that's a very difficult situation. But ultimately, it will have to be the family if the patient cannot decide for himself.
Okay. Thank you.
Um,
Next.
yeah, actually, that's what we call substitute decision making. So, pero from the start, I would encourage that even before you get to the point that the family member is demented, um, not demented, but having a really um, difficult time making decisions already, you open up the topics na. Not because you want them to get cancer, but because you want to give them control of the situation. Um, so once your family member is diagnosed with mild to moderate dementia, pag-usapan nyo na. And then even yung mga little things like uh, kanino mapupunta yung alin, yung mga ganun. Or anong ospital mo gustong dalhin ka. Things like that. Para at least alam niyo, komportable kayo as family members na this is what daddy wanted. And you have no regrets. And you have no, kasi yung decision making, even if it's substitute decision making, sometimes isipin mo talaga, you think that's what daddy would have wanted.
Yeah.
Tapos kunyari, 5 kayong magkakapatid or 4 kayong magkakapatid, tapos dala-dalawa yung iba-ibang desisyon, tapos yung iba nasa States, yung mga ganun. Whereas if you say, this is what he wanted, he told us, then kampante kayo, na comfortable kayo. But if that happens, na talagang walang nasabi, sometimes, di ba, Dr. Malilin, that's when psychiatrists get called in.
Yes, a lot of times.
to mediate kasi they don't know what they're going to do na.
Yes.
So, and also bioethics actually. That's when bioethics gets called in. Kasi sometimes communication is difficult.
Yes, yes. At the end of it all, di ba, it boils down to what will benefit the patient, no? And what the quality of life will be for the patient. Yun yung dapat maintindihan ng family talaga.
And kasi
And
the
doctors.
families have a lot of issues aside from the medical problems that we
And
have
the
to deal
doctors
with.
also, ha?
Yes.
Kasi a lot of doctors are still not comfortable, they're still very aggressive. So they have to, yun nga, put everything in its proper context, no, when deciding. And yeah, it should be a collaboration between the doctor and the patient and family. Lalo na sa Pilipinas, family. Kumuha nga lang ng memorial plan, nagagalit na, di ba? So, how much more pag pinag-usapan yan? Pero I think it's about time, no, that we start talking about it. Sa probinsya, hindi pa rin talaga, hindi pa rin acceptable yung ganyang klaseng discussions.
I think this pandemic has actually spurred a lot of people into those conversations because they realize that when their relatives get COVID, they're not able to talk to them after.
Yes, that's true. That's true.
Yeah. So, in a way, maganda rin because it's open channels.
Yeah. And technology has given us some leeway in discussing it on air, and they can, review it every time they want to. Thank you, technology. Okay, Dr. Babes mentioned here, saying the bad news is really difficult, especially if the patient is a breadwinner. And the family members will tell you, please do not disclose. Lalo na kung mga bata pa, yung mga in their 40s, 50s, no? So, it's really, doctors should be trained to communicate well. Dapat sa medical school pa lang. Kasi pagdating nyo sa clinics, magugulat kayo kung ano nangyayari Diba?
There was a time, Dr. Ramadi, when I was a resident at PGH, And we would get referrals in CL from IM. Parang napapansin namin there's a certain doctor na parating nagre-refer for disclosure. Kasi she or he would need help disclosing. So
Yeah.
parang na-realize namin na this doctor has problems also.
Yeah.
So I think kinausap namin siya eh. This very discreetly. Through channels, kinausap namin na,
Oh.
dude, may problema ka ba with it? Kasi baka mamaya we can help you.
Oo.
Yun.
Yeah, we really have to conduct communication training, communication skills training for our young doctors and our
Mm-hmm.
students.
Mm-hmm.
Kasi they need it eh. Well, not everyone are really good communicators, but when you're already in your private practice, you really have to do it. There's no other way.
Mm-hmm.
And with practice comes confidence and comfort in doing it.
Mm-hmm.
Maski naman
Yeah.
tayo nung una, di ba, para. Okay, there's a question from Dr. Cory Makalintal. What do you do when the relatives insist not to tell the patient that he or she has terminal illness for fear that he or she might just get depressed and hasten death?
Mm-hmm. Mm-hmm. I can say something about that. Um, Not that this is what, of course, this is not what I tell them, but coming from a knowledge that typically when relatives request that, it is usually a projection of their own fears. When they think na baka hindi niya kayanin, baka ma-depress, they're usually, more often than not, verbalizing what they're afraid to face themselves. So how do we help relatives when they make those requests? So it's not always easy. We would well, what I would usually say is that is it okay if we ask the patient what they want to know? No? So I always go the route of can we just ask permission and let them decide? And usually with that relative present, kung nagkakataon, para sila ang nakarinig na the patient wants to hear. Because a lot of things go assumed, na parang ina-assume natin na ayaw niyang malaman. And there have been patients who actually say, yes, I don't want to know anything. Just please tell everything to my children. And so at least alam ko din, and natanong natin. But some relatives are actually surprised when the patient will say, I want to know everything and I want to be part of the decision making. So at the very least, I try to offer, can we make the patient decide for himself or herself kung gusto niyang malaman o hindi, right? It's hard to assume. And usually I also try to say that yung mga ayaw talaga, for those who just now, wag talagang sabihin. One thing I want to say also is that, you're going to the cancer center for treatment or consult. Do you really think the patient does not know? It's like sobrang tremendous amount of suspension of disbelief, diba? Na they don't know. So I would say, like, coming from my field, usually they know something's up. And you know what else they know? They know that their family is keeping something from them. And that adds to the hurt, that adds to the burden and the worry, and the things that they carry. So basically, yeah, and trying to sort of show them also na, kayo ba, sino bang gusto nyong gumawa din ng mga decision if it happens to you? So it's basically trying to show them how, other ways of looking at things. But yeah, so those are some of the tactics that we try to use when patients or relatives request for those things. Yeah.
That's a really good way of doing it na asking the patients in front of them. Kasi nga, they need to hear from the patient na, okay, I'm ready. Parang kasi pinapangunahan nila minsan.
Yeah.
And even actually psych referrals, ni-refer mo na sa psych para matulungan ng psych. Para hindi ma-depress. Ayaw din nilang paalam na may psych referral. So minsan ganun din, nagtatago tayo ng ano natin, ng, um, ng pangalan natin. I'm part of the medical team. So minsan ganun din eh. Pero kasi parang it's hard to assume. Don't assume that the patient will get depressed automatically.
Yeah.
And if they get depressed, okay, they get depressed. We have solutions for that depression naman eh. We can help them.
Yeah. Yeah, I remember I had this. I'm telling this because I got the patient's consent, ha. I have this referral before, 6, 7 years ago. So the patient was referred to me for depression. Hindi talaga magamot. So sabi ko, I don't think this is just pure depression. So turned out, patient had malignancy related to her liver and pancreas that manifested with depression. So, ayaw nilang pasabi kasi nga depressed na yung pasyente. Lahat, family, the doctors, no? Kasi mabait talaga yung pasyente. So, sabi ko, well, let's see what her level of readiness is. Pero talagang takot na takot yung main doctor kasi ano na bait-bait ng pasyente, ayaw nilang ma-distress. Sabi ko, sige, I'll try my best. So, finally, when I asked the patient, what do you want to know? Yun lang yung tinanong ko sa pasyente. Ang sabi niya sa akin, I want to know everything. Oh, sabi ko, okay, so I'll talk to your doctor and tell him that you want to know everything. So, nakakatawa kami, para kaming ano doon sa labas ng, sa corridor, nakalinya sila. So anyway, bumalik yung doctor. Tapos nag-antay rin ako kasi baka nga magkaroon ng distress reaction. Pero in a short while, lumabas yung doctor and sabi, Mads, anong ginawa mo? Tinanong ko lang siya kung anong gusto niyang malaman. Sabi niya, kasi ngumiti yung pasyente when the patient finally knew her diagnosis. Kasi daw, for the longest time, she doesn't know what's bothering her, what's the matter with her. But now that she knows the diagnosis, she knows what her enemy is. Yun yung sabi ng patient. So, yung mga ganun ba na situations na hindi mo makakalimutan eh. Hindi mo talaga makakalimutan. So, yeah, it's just a matter of asking the right questions the right way. No? Okay. Another thing is, what about an adult, a mother with younger children? How do you disclose or how do you tell the children na teens pa, so minors pa, about the illness? Hirap.
That's so hard. One advice that I received before when dealing, actually this one now was with young children pa eh, was to use kumbaga not to hide, not to use veiled language in talking with the children about it. For example, ouchie or boo-boo, you know, kasi the kids will not be able to distinguish it from, you know, what they really call boo-boo or ouchie. So parang yung example na binigay was the grandfather has a boo-boo. But it was actually cancer, so that they were trying to say it slowly to the child, and then suddenly the child starts crying because something happened. Why? Because my friend got a trip or something, and then the teacher said she wasn't in school because she had a boo-boo. So parang suddenly there's that association and confusion, no? So it makes it more difficult. So if it's cancer, call it cancer. You know, parang, you know, parang the child will learn what it is eventually. But, you know, parang the point din naman of disclosing to the children is because you will need to help them also through the whole process of treatment and bereavement as well when that comes, to have that open communication with them as well. So that's more for young kids, no? Pero I think for even the teens, everyone just needs support. There's really usually more harm that is wrought when we hide information from everyone, whether it's the patient or relative. So usually being gentle and being supportive to everyone concerned, I think.
Yeah.
And also, given that technology nowadays, they will research, and the kids are very, very savvy when it comes to the computers. So I would actually even give them the websites, perhaps. It doesn't have to be the NIH websites or anything, but at least, they don't go into blogs and yung medyo unreliable sites. But
Yeah.
there are targeted sites for teens and for other age groups. So you can give that information to them. And even adults, actually, it's like yung, di ba, when we call uh, PTB, when we call pulmonary TB, ano nga ba yung mga euphemism na ginagamit nila? Or even yung mga tumor, may mga bukol. Kasi may mga pasyente sasabihin nila may bukol daw ako and then they don't realize it's cancer because they don't say the C word.
Yeah.
So, yung mga ganon, parang ano yun yung information disclosed is not enough pa rin. So, tama si Dr. Pauline na when you say it's cancer. Just be matter of fact about it, say it's cancer. And that a lot of cancers have better prognosis now. We're lucky in that sense. Depends So don't encourage that sort of AKA mga ouchie, even for adults.
Oo. So, name it as it is. Pero yun nga, it's the manner of delivery. So, and always offer support. Yun nga yun eh. You really have to offer support. Tapos for younger children, yun talaga mga toddlers, it's really best to talk in their level of language, no? Developmental level nila. Okay, may ano pa dito?
Can I add something pala, Doctora?
Sure.
Something about, sometimes it's really useful it's part of the acceptance of the inevitability, and especially when it comes to children, no, who might be too young to comprehend everything. Something that gives the patient, oftentimes, if it's a parent, something to do and something to accomplish, is to leave something for the children. It's some sort of legacy that they can give them, like maybe a letter or even taking a video message, something that they can hold on to, something that they can experience, no, when they're older and can understand more. So that's something very special. And usually, kapag may takot kasi silang sabihin to children, you can give them something like this to do. Para it's a purpose that they want to be able to accomplish in time. So that's something very, very special that we can offer also to parents.
Yeah, that's true. That's true. Yung patient ko, that same patient, what she did was she composes kasi. So she made this song for her daughter. And then when her daughter turned, I forgot what age, she let her listen in, or may music video pa, di ba? Pinanood niya yung music video. So hindi pa siya patay, pero pinakita niya na dun sa daughter niya. Nakakatuwa. So actually, discussions about death and end of life can be beautiful, no? Pwedeng hindi siya morbid kasi what can you do, no, is really to preserve the dignity of the person and the family. And that's very important at the end of life. That's really very important. And it's true na even among doctors, meron talagang hindi pa rin nila kaya na pag yung family member or sila mismo is facing that, no. But it's best to really discuss it with them. Open the discussion. Yes, Meg. Gusto ko sabihin.
And you got me thinking na when kasi we think of doctors as doctors. But at that point kasi they're not doctors. They're family members and they're grieving, or they're patients and they're grieving also. So think of him that way, not as doctors.
Yes, yes.
Kasi they're really just people.
Yeah. Yeah. Okay. Any more questions? Ato, sabi ni Dr. Babes, I suggest the psychiatrist should be a part of the holistic approach in dealing with end-life issues. I think in St. Luke's and in other big hospitals in NCR, they are. Pero siguro we have to reach out more to the other hospitals in the provinces, no? Educate them more. Kasi it's a vital um, support is a vital part of caring at the end of life, especially not only for the patients and the family but also for the doctors kasi the doctors can also feel distress, di ba? Sanay lang tayong nagiging matatag, but deep inside, no, when you're attached to that patient, you feel distressed that you cannot do anything anymore. And you just feel the sadness when your patient passes on. So yeah.
And actually, even palliative care, when I was pre-pandemic, when I would go to the hospital and there's a cancer patient, um, or, a patient who is dying, and then I suggest palliative care, the nurses in St. Luke said before, the nurses would say, may palliative care ba tayo dito? Meron! Ako magsasabi sa kanila, they're not aware that the service exists.
Oo.
So parang it really, even within the big hospitals, the staff should know that
Yes.
there is such a thing.
Oo.
And they can help. They really can help.
Yes, yes. And sometimes, Meg, when I do my rounds at the nurses station, tatanungin ko yung mga nurses, okay pa ba kayo? Okay pa ba kayo? Lalo na pagka nawi-witness ko, merong isang very agitated family member who's berating a staff. Talagang naaawa ako sa nurses. So parang nurse rounds ang tawag ko doon. Inukumusta ko lang sila. Okay pa ba kayo? Okay pa, doktora, pero umiiyak na. So yun, hindi lang yung pasyente at family. Everyone is affected when there is death. So, yeah. We should have more discussions like this in the future. Correct?
Yeah.
Kala may sinabi si Babes. Ayun. Sad to say, it takes time to be comfy to talk about death. At times, we are overwhelmed when patients would say, I am ready to die. Not all patients who accept death are depressed. True. They are prepared and ready. Yeah. The doctors are not.
I wanted to recount one story that was shared with me by a friend. Actually, she's a nun friend, nun as in religious sister. Um, and this is in connection with doctors being comfortable talking about that. And I think really just knowing what is okay, what should be okay at dapat hindi. Because if the doctor himself or herself is not comfortable or is unsure if
Yeah.
something is permissible, um, mas lalong hindi makakapag-desisyon yung family or relatives, right? So this particular madre friend was telling me na her father was it was in the province, admitted in the ICU or something, and the family, the children were actually saying it's okay, parang we know the wishes of our father and we want to withdraw the ventilatory support. And then it was the doctor attending yung naka-duty sa ICU na sobrang siguro na-imagine ko pinapawisan na siya. Parang hindi niya alam, he didn't know how to respond. And we know because we're not really taught in lectures to or practice how to do it. We're just endorsed, di ba? Nasasabihin mo the safe side na have them sign the waiver and everything. And then meron pang sinasabi na we cannot be the ones to unplug. As if, it's not naman just or yung pulling out the tube. Where do we get these rules, no? So they're not really legit instructions. Pero yun nga, we don't know kung ano yung totoo, kung ano yung dapat tinuturo talaga. So we need to inform ourselves, through things like this, through avenues like this, and we have to come from a well, that's when we need to put our coats and hats on as doctors para we have the authority to be able to equip our patients and family as well on what's going on to help make decisions.
Yeah, yeah. Okay, there's a comment here by Joey. My son was diagnosed with chondrosarcoma and referred to palliative. Pero until now, wala pa po kaming palliative clinic na napuntahan. Very challenging kasi lalo na ngayong pandemic, a lot of clinics closed. So I don't know if the one in PGH is open. Open ba, Meg? Would you know? Nag-close ang OPD nila eh.
Yeah,
Mm.
close ng OPD eh. Kasi I think they're trying to focus on the COVID.
Yeah, yun nga.
So other hospitals would have palliative care clinics also.
Oo. I think National Children's Hospital also have. That's the one near St. Luke's QC, right?
Yes.
And yeah, St. Luke's has physicians naman who usually they are ANES or usually ANES actually being
Oo.
in
Or
palliative
family med.
or family med yun. So you can call concierge and ask, get an appointment. It doesn't have to be face to face naman. I think they offer
Yeah, now they can do
yeah.
online consultation. Yun yung maganda sa technology. You know what? Before it was not acceptable for us, no? But now we've come to embrace it. Okay, so if there are no more questions for our speakers, I'd like to thank Dr. Pauline Cauton and Dr. Meg Busuego for giving us this time to talk about this difficult topic. And yet, we know that all of you who have watched the webinar will go home or get back to your life more equipped with more information. No? That this afternoon's webinar has been a learning activity for all of you. Thank you very much, Dr. Meg and Dr. Pauline. May God bless you always. And I hope to see you soon, Dr. Pauline, face to face. And Meg, thank you
Thank
very
you.
much. Thank you very much. So, if you have any more questions, you can just call our contact local number. It's in the posters. If you need to talk to someone or just ask Darlene, our administrative assistant there. Thank you very much. That
Thank you,
ends
Dr.
our
Meg.
webinar.
Thank you, Dr. Pauline.
Bye. Take care.
Thank you.
Ingat
Thank
po. God
you.
bless.
Hi, Doc Maddie.
Hi! Joey,
Yes,
tinatype ako sa'yo.
tinatyping talaga.
Hospital ng Makati. Yan. They have palliative service there. Sigurado ako sa Hospital ng Makati kasi yung friend ko ang head, si Dr. Ara Ofina.
Wow. Yung referral kasi, Doc, is matagal na. Can we use it pa ba?
Oo.
Mm, so,
Pag nakita
hindi
niyo si
na,
Dr. Ara, you tell her, I referred you to them.
verbal lang, Doc.
Mm-mm.
Verbal ko lang sasabihin. It's Dr. Ara and
Ara Ofina.
medyo kinakabahan kasi ako, Doc. What will be the next approach to Ivan?
Oo. Okay, Joey, maybe we can discuss this na lang in our messenger, ha?
Sige po, Doc. Sige po, Doc. Thank you
Okay.
so
Thank you
much.
for
Bye,
coming.
girls.
Thank you,
Thank you.
Darlene. Thank you
Thank you,
for
Dr. Maddie.
Corp
Okay,
IT,
Doc.
lahat.
Everyone.
Okay, bye.
Bye, Doctora.